Hi everyone, welcome to ResearchMD.com. We got another great presentation today. Let me introduce myself. My name is Dr. Pramil Cheriyath. I'm a physician in the United States, Program Director, Internal Medicine Residency Program and Transitional Residency. I'm an Associate Professor of Medicine in two large medical schools in the United States. We've been doing a series of lectures on endocrinology. We started with posterior pituitary hormones, and then we went to anterior pituitary hormones, and in the last few weeks we've been covering extensively hypothyroidism. If you have a chance, please go back and watch those videos. And all these videos are not very long, between 9, 10, 11 minutes. You got a very good understanding what's going on. Today, our purpose is going to teach you all about hyperthyroidism. Okay, when we talk about that's our topic again, hyperthyroidism. Let's look back and define our topic today. What is the definition? Excess thyroid hormone synthesis and secretion from the thyroid gland. Okay, so that is what the definition. Now look at epidemiology. The prevalence in the United States around like 1.3%, and of course females, just like all other thyroid disease, females to male ratio in this thing around 5:1. And then it increases with age also. Okay, now you come to the etiology, causes. You got this large classification. Two major classifications we need to know is thyrotoxicosis with hyperthyroidism and thyrotoxicosis without hyperthyroidism. That means when you talk about thyrotoxicosis with hyperthyroidism, thyroid gland gets stimulated, more secretion. For this one, like it's already stored and the one kind of released from the thyroid. It's not much stimulation like more secretion, okay? So we need to understand that. Let's look back. Let's start with the thyrotoxicosis with hyperthyroidism. What is the most common is the TSH receptor antibody, okay? It's also called thyroid stimulating immunoglobulin. Okay, TSI, that is the other word for also for, of course, Graves' disease. And then you can have inappropriate TSH secretion by TSH secreting pituitary adenoma and the pituitary resistance to the thyroid hormone. Okay, now excess HCG secretion. We know beta HCG receptor is similar to like TSH receptor. It can bind to the thyroid and produce thyroid hormones. Usually happens in pregnancy. Remember we talked about in the first trimester when beta HCG is extremely high. Here what happened is like beta HCG is produced by like trophoblastic tumor, and it's also produced by when you have like hyperemesis gravidarum. When the first trimester when you get pregnant and all that. Now, then you have autonomous thyroid function, like solitary adenoma and multinodal goiter. And then you got activating mutation of the receptor or GS alpha protein. You got familial known autoimmune hyperthyroidism. Okay, these are the main thing we know when we talk about thyrotoxicosis with hyperthyroidism. Now the next major category is thyrotoxicosis without hyperthyroidism. Okay, so what do you have? Inflammation and release of the stored hormone. That's what happened. There's not much stimulation and production. There's already the hormones are stored and they get released. Let's look at autoimmune destruction of the thyroid. You got silent thyroiditis and postpartum thyroiditis, right? And then you got viral infection. Viral infection like subacute granulomatous thyroiditis. And then you got toxic drug effects. We know like the drug induced, especially amiodarone and lithium. We know how much they interact with that. And then you got the bacterial fungal infection. You got suppurative thyroiditis. And also in radiation, you got, of course, radiation thyroiditis. When we look at the extrathyroidal source of the hormone, right, we have to talk about the excess intake of the thyroid hormone. What is it usually people take? A lot of people can abuse it to lose weight. That's a common phenomenon in younger people, so you have to watch out for that. And then ectopic hypothyroidism, we got thyroid tissue kind of implanted somewhere else, right? Stroma ovary, functional thyroid, and even the functional thyroid cancer metastasis, you can have like ectopic thyroid. And then ingestion of contaminated food in hamburger thyrotoxicosis. What happens is like when you have animals, especially cows, and you get slaughtered, you're not supposed to take the larynx or the neck part, you have to throw it out. There's a law, but in some cases, like what happened, they take that tissue also, grind it up with your meat, and then you got excess thyroid production, okay? So that's what happened. There's a lot of, there's some case reports about people living in a community. They were slaughtering cows, but they forgot to throw the neck where the larynx and the thyroid tissues out. Instead of that, they kind of grind it up with the other tissues, and then you can have excess thyroid. Now, exposure to excessive iodine, there's syndrome Jod-Bastedo effect, iodine-induced hyperthyroiditis. You got iodine containing drugs, and the radiographic contrast also, some of them can contain iodine that can cause that. So remember, two major classification again: thyrotoxicosis with hyperthyroidism. That's where more stimulating of the thyroid gland and the secretion. When you talk about thyrotoxicosis without hyperthyroidism, mainly inflammation and release of the stored hormone. Remember that. And then you have the other major extrathyroidal sources, which ectopic thyroidism, people taking extra thyroid to lose weight and all that. So once we have, let's look at our clinical presentation. What is the clinical presentation? Everybody knows the constitutional symptoms like, the heat intolerance, sweating, the polydipsia, weight loss is very common, like diarrhea and all that. Neuromuscular, you got tremors, nervousness, you cannot concentrate. And then you got cardiovascular, tachycardia, atrial fibrillation is very common in these people. Make sure, we have a new onset atrial fibrillation, make sure you check your thyroid function. And you have pulmonary shortness of breath, GI, of course, can cause like hyperdefecation. Diarrhea is very common. Skin, because of increased perspiration, sweating. You got reproductive abnormalities like menorrhea, and you got like menstrual irregularities. That's what we need to know. And you got ocular, you got diplopia, proptosis, chemosis, periorbital edema, even ophthalmoplegia. These people can have it. Okay. So remember, don't forget to check for the eye symptoms and all that. Now we have this, clinical presentation already. How do we investigate? We got a nice algorithm right here, what we have to do. Of course, when you have to take the history and you're suspicious, you start with the thyroid function testing. You measure the TSH, you measure the free T3 and T4, okay? And total T3 and T4 also you can measure. And then, if you look at the first thing we need to make sure is not subclinical hyperthyroidism. How do you know that? TSH is going to be decreased, but free T3 and T4 is normal. That's called subclinical hyperthyroidism. Okay, so you have to rule that out first. And then, if there is decreased decreased TSH and increased free T4 and T3, we know there's hyperthyroidism is going on. Okay. In that group, what we need to do is we do a radioactive iodine uptake test. Okay. Once you have the radioactive uptake test, you can put it into three categories: high uptake, which is focal or asymmetrical, or you can have high uptake diffuse, or you can have low uptake. Okay, when you give the radioiodine testing. So let's look at the first one. If there is high uptake and focal and asymmetrical, you can always think it's a toxic multinodal goiter or toxic solitary adenoma. That's our diagnosis there. Okay. When you have high uptake and diffuse, the case is closed. That's you got Graves' disease, okay? And then you have low uptake, then you have to worry about thyroiditis, iodine and drug induced, and then you have to worry about excess exogenous thyroid hormone, especially ectopic hyperthyroidism, all this causes, okay? So make sure you do this radioiodine uptake test, and then you put them into three categories: high uptake, which is focal; high uptake, which is diffuse; and then low uptake. Then you have to worry about thyroiditis and ectopic thyroid hormone and all that. Okay. Now let's look at, and you also do a thyroid ultrasound and you check for TSH receptor antibodies or thyroid stimulating immunoglobulin. That's the other name for it. So you do a thyroid ultrasound and you have to do TSH receptor antibodies also. Okay. Now, when you have a variable ultrasound finding and then you have thyroid TSH receptor antibodies are negative, then you can think about thyroiditis. You got iodine and drug induced. You can talk about the ectopic thyroidism, hyperthyroidism. Okay. When you do ultrasound and then you found out there's nodularity and but when you checked about the thyroid TSH receptor antibody is negative, then you have to think about toxic multinodular goiter or toxic solitary adenoma. That's your diagnosis, okay? Now, when you do an ultrasound, you find an enlarged thyroid, but there's no nodules in it, okay? Then you also check the TSH receptor antibody, that's positive, and your diagnosis is very clear, that is Graves, okay? So 3 tests, pretty much you have to do. One is radioactive iodine uptake test, and you do a thyroid ultrasound test, and then you also check for TSH receptor antibody, which is also called thyroid stimulating immunoglobulin. Remember that, okay? Now, let's say you got normal or the increased TSH and increased free T4 or T3, there's inappropriate TSH, then you have to think about the, TSH secreting pituitary adenoma or pituitary resistance to thyroid hormone, you have to know that. Okay, now when you talk about normal TSH, normal free T4, free T4 and T3, pretty much it's like euthyroidism, that's pretty much normal, okay? So let's stay back, look at our whiteboard, I have everything kind of briefly summarized, very, very important topic. We know the definition, increased synthesis and secretion of thyroid hormone. We know it's much more in females. It increases with age, also you have to know. Then you have to put 2 major categories, thyrotoxicosis with hyperthyroidism and thyrotoxicosis without hyperthyroidism, okay? When you talk about with hyperthyroidism means it's like stimulation, increased secretion of the thyroid hormones from the gland. When you talk about thyrotoxicosis without hyperthyroidism, that means inflammation and release of the steroid hormone and extra thyroid source of hormone. Those are 2 major categories we need to know. And then we look at the clinical presentation, you need to know the constitutional symptom, we know like heat tolerance, diarrhea, like weight loss, then you got the neuromuscular symptom, we need to know like poor concentration, tremors, cardiovascular, tachycardia, atrial fibrillation, and then we talk about pulmonary, GI, skin, reproduction, make sure ocular, don't forget it, you got chemosis, proptosis, ophthalmoplegia, you got diplopia, those are the main symptoms you can have. Now then we have this, come to this nice algorithm up here, okay, you always check first the TSH, and then you got free T3, T4, and all this need to be checked, and make sure you rule out it's not subclinical hypothyroidism. When you talk about subclinical hypothyroidism, that means your TSH is decreased, but free T4 and T3 is normal. Okay, once you rule that, then you find your classic hyperthyroidism, decreased TSH, and increase free T3 and T4, that's where the investigations take in, right? Then you have to do radioactive iodine uptake, and then you do a thyroid ultrasound test, and then you do a TSH receptor antibody, okay? And then when you radioactive iodine uptake, you need to know high uptake focal, you got toxic multinodular goiter, high uptake diffuse, you got Graves, you got low uptake, then you have to worry about like thyroiditis, you got iodine induced, drug induced, and then you have to worry about the ectopic problems, right? Here you come, you do the thyroid ultrasound and TSH receptor antibodies. If you got variable ultrasound finding but no thyroids on the TSH receptor antibodies, then you have to thyroiditis, iodine-induced ectopic tissues, you need to worry, right? When you have a nodular goiter and you got the TSH receptor antibodies negative, then you have to think about multinodular goiter, right? Or it could be like toxic solitary adenoma. Now, of course, we need to come to Graves. What do you find? Enlarged thyroid. You can have TSH receptor antibody or thyroid stimulating immunoglobulin. That's going to be present. Then you got the diagnosis of Graves. Okay. And then you got to make sure you got, if it is like increased TSH and increased T4 and T3, we know this kind of something wrong with the upper level, like, with the hypothalamus or like pituitary, right? So TSH secreting pituitary adenoma, pituitary resistant to thyroid hormones, we have to look at it. And then, of course, if everything is pretty much normal, you classify as euthyroidism, okay? So that's in a nutshell about hyperthyroidism. Tomorrow we'll be back with how to treat hyperthyroidism. Very important. Please subscribe to our channel. We'll be back with another presentation soon. God bless. Thank you.